كورونا؟
كورونا أحسن.
أحسن.
يعني in our hospital they closed the COVID unit, so we're not getting a lot of admissions, which is good.
Okay.
So that part is better, alhamdulillah.
يعني there is any number of, I mean, new COVID per day in?
Yeah, but not too many admissions, and the death rate is still very low. More people are testing positive, but it's not as bad as before.
Okay.
Have the vaccines arrived in Lebanon yet?
Yeah.
They are using which vaccine you are using?
We have Pfizer, we have AstraZeneca, so we have both.
Okay. دكتور علاء, I think الوضع في مصر برضه صار متحسن, صح؟
Yeah, it's more stable now. It's I think it's good. Most of the units in COVID-19 is closed now. This rate is about to be 0 in my local area now. It's good.
0 in the number of new patients?
Of death. No, death rates.
Death rates.
Yeah.
Okay.
Yeah. The death rate is 0, but the admission is still about maybe 5 to 6 per days in the area near me, for my friends and colleagues there.
Okay. How about UK, Fahad?
So the UK is interesting. Obviously, most of the elderly and the vulnerable group have been vaccinated, but there's still a lot of young people who haven't been vaccinated, and yet the government is still very keen to push and unlock the whole country and have no restrictions from the 19th of July. So in the medical field, we're a bit nervous about that, because although younger people who catch COVID, inshallah, their risk of death is low, but there is still a hospitalization risk that's at least double or triple, that you get with a normal flu season. So I think it will stress the NHS. So I'm just hoping that so now anybody over the age of 18 is entitled to get a vaccine, but still, unfortunately, due to hesitancy, the uptake isn't 100%. We're still 60% double vaccinated, 80% single vaccinated. So there's still a good chunk of the population that isn't. So I'm just a little bit worried, but inshallah khair.
Our invitation is that we will start by 9. So most of the people, they will just start joining from 9 and so. So we will give another 2 minutes maybe for attendees to join us. Our meeting also is live on Facebook and YouTube. We have so many people, they are attending in Facebook and YouTube. We hope Ahmed to connect soon. Dr. Arula, I think you are the first one, but Dr. Ahmed Salam, he faced some problem in the electricity and they couldn't do the surgery, as he called me.
Oh,
And he is asking to be the first one if all agreed. Dr. Ala and Dr. Fahad.
Sure, no problem with that.
No problem.
Dr. Arula, we need to hear you because you are the first one.
yes.
Okay.
So should I go ahead, or you said Ahmed will start?
Ahmed, he want to start, but
start?
that's why he asked me to do that
Yeah.
because he was thinking to finish the surgery, but unfortunately the surgery was delayed 2 hours because of electricity. Happened something electricity in his hospital.
You think he's in Beirut?
There is no different. Electricity available everywhere, and the problems can happen everywhere.
You are right, Dr.
It is unusual because normally in the West anyway, certainly in the UK and the US, they all have their own generators. So that did happen to me once, where the
We
electricity
can ask
came
Dr.
out.
Ahmed. He's now with us. He can give an example.
Fine.
Yeah, hi. I'm very sorry for being late. I sincerely apologize. How are you doing, Rola and Fahd and Dr. Ale? How are you doing?
How are you? How are you, Dr. Ahmed?
We are talking about you, Ahmed, by the way. We are talking that
Me?
you have a
What
problem
did I
of
do?
about
What did I do?
electricity problem in United States. Rula
Yes,
saying
yes,
say it's like Lebanon, so no difference.
that's true. We had problem with the aircon, so the cases got postponed, and now we're trying to deal with the aftermath. All right, we're
Yes, we can start within 1 minute. We will give another only 1 minute more, then we will start. Also very difficult, Ahmed. You are working on Fridays, but I think you get used to that.
it's very difficult, and I'm trying to change this really, and with the prayers as well. It's really difficult. I'm hoping, inshallah, next year should work better.
Okay, so I think the time is good now. We are about 9:05. So, and most of the, we have some sort of attendees. Good. Assalamu alaikum wa rahmatullah. Good evening, good morning to everyone, because I think good morning to Ahmed, good evening and good afternoon to Fahad, good evening to Dr. Rula and Dr. Ala, and good evening to our attendees in the Middle East. I would like to welcome all of you to the MEOM Middle East Ophthalmology meeting. And today we are, actually, I am proud to have a very eminent speaker, especially in our area. And also I'm proud also to have Dr. Ahmed from United States and Dr. Fahad from United Kingdom. So I will just introduce most of our speaker first, then we can go directly to our presentation and cases discussions. Our first speaker will be Dr. Ahmed Salam. He is an MD, PhD, FRC of Ophthalmologist, Associated Professor, Retina and Uveitis Director, Uveitis Service, Johns Eye Institute, University of Arkansas for Medical Science, Arkansas, USA. Our second speaker, it will be Dr. Rula Hammam, is an associate professor of ophthalmology at American University, Beirut. She is the director of the residence training program and the medical retina fellowship training program. Also, we are having Dr. Ala Radwan, ophthalmology consultant in uveitis and medical retina, Masr Uveitis and Retina Center in Egypt, head of Egyptian Uveitis Society, Cairo, Egypt. And also to introduce my friend, Dr. Fahad Kohel, consultant ophthalmic surgeon in Royal Hampshire Hospital, England, a consultant in medical retina and uveitis. All the time I have a difficulty to pronounce his name of the hospital, but no problem, Fahad. I think you can.
We forgive you, Mohammed.
Okay,
It's okay.
thank you very much. Thank you. Okay, so Ahmed, the mic with you, please. You can start.
Thank you so much, Dr. Mohammed. It's a privilege to be here with the distinguished panel, Dr. Rola Hammam and Dr. Ala and Dr. Fahd, and I'm really honored, and thank you so much for the kind invitation, Dr. Mohammed. I'll share my screen. I have one case, and again, I apologize to everyone for being late. Okay, well, sorry, wrong slide. Okay. All right, okay. Can you see my screen?
Yes, Ahmed, we can see very clearly.
All right, so this is a 38-year-old man referred in for, sorry, I'll remove these. Okay, referred in for pressure, like pain in the eye, followed by flashes of light, and now
Ahmed, we can't hear you. I think there's a problem in, okay.
Yes, it's okay now, the sound.
Can you hear me now?
Ahmed, can you hear?
Yes, yes, it's clear.
Can you hear me? Okay.
Yes, yes, now we can hear you.
Oh, I'm sorry. Okay. All right. So this is a 30-year-old gentleman, pressure, pain that resolved within a week. Then he had flashes of light and now partial loss of his visual field. Otherwise, he's healthy, no medications. He lives locally, no exotic travel, one female partner, and no intravenous drugs, and no pets, and nothing really exotic in terms of any weird social activities. That's the appearance here of the right and of the left eye. And here, just to, sometimes it's difficult to see on slides. So this is the area which looks really abnormal here highlighted. Now we have fluorescein and ICG of the right eye. I'm sorry, I'm trying to get rid of this bar. Okay. And of the right eye here continues. This is the 6 minutes fluorescein and ICG.
Ahmed, you want to interrupt or you want to continue, or
I think if you want to do it the way we discussed and you were, we'll do that.
Yeah, if someone have, yeah,
I'll come to the differential and stop, and then maybe see what our panel would like.
To ask.
This is the OCTA here of the right eye, and that's the most pronounced area here in the OCTA, and this slab is at the level of the choriocapillaris. So there's decrease here in the OCTA signal flow. And then the question really is the differential diagnosis and what's on the top of the list, and then we can go from there. So if I interrupt here, I'll get you I think that's the most, and the left eye was otherwise really not much seen.
Okay, so we can open everyone, if there is any comment from Dr. Rola, Dr. Ala, or Fahad, or question to Ahmed. Yes, Fahad.
Tell me if this was any preceding viral illness.
No preceding viral illness, and that's really all the finding that we had. No.
And again, no history of previous infectious disease like TB or anything like that?
No, there was nothing really, no history of any previous infection disease.
And nothing on systemic inquiry that might, suggest some kind of inflammatory, which could cause an inflammatory choroidopathy?
No. So, and the only problem really is mainly in this area, and the antechamber was quiet and nothing, and just decreased vision. And he got really a central defect in this area, as he describes it. And then the picture is on the fluorescein. and the ICG. So I think maybe.
But Ahmed, you mentioned also in the beginning that he have some viral, maybe rash, maybe, and he took antiviral 1 year ago, right?
Did I? Sorry,
Yeah,
maybe
I
missed
saw
that.
in the yes here the rash over
Oh, that's
much
yeah.
of his.
Sorry, I apologize. That he had
Yeah.
he had a rash.
Yeah.
He had a rash over the body, and he took that steroid and antiviral. That's like a long time ago. Yes.
1 year ago. Okay.
That's 1 year ago.
Okay,
So
there is a
at the end of the-
questions.
And
Yeah.
that just for
Sorry,
rash. Yeah.
Sorry, Mohammed.
Yes.
So, I mean, where he's shown is a patient with a unilateral choroidal hypofluorescence, which is very elegantly showed by the OCTA. And at the end of the day, is it inflammatory? Is it infective? Is it secondary to circulation? Is it an embolus? So it's those kind of things, really. So at the moment, I'm drawing a blank, because if I saw this patient, he'd be having lots of workup. I'll be trying to work out, is there, an embolic cause? I would do a full, workup for vasculitis. I would obviously work him up for infection, maybe even send off a kind of, blood culture. I'll be looking very carefully, at the other eye, and then maybe even ask the internist to help me, particularly to see if this rash, might be relevant. So at the moment, I know exactly where the pathology is, but I couldn't give you a diagnosis given what he showed us so far.
I think that's really fair enough. It's just, I mean, the thing is like, which direction shall we go, and what's the pathology? So, Dr. Ale, I mean, on the I'll leave the moderation with Dr. Mohammed.
It's okay, Dr. Ahmed. We are discussing. You can't go ahead. Okay. No problems.
I have one question still, Dr. Mohammed and Dr. Ahmed. So, did the patient receive the vaccine for COVID in the last 3 months?
No, this was actually at the COVID time, but before the vaccination.
Yeah.
And he was not tested for COVID.
His wasn't tested. Okay.
Yeah, that was like, actually, that was the beginning of COVID time. He was not tested for COVID, and there was no vaccination. Yeah.
Okay.
Okay, Dr. Arula, if you have any questions to Ahmed or suggestions.
I agree with Fahd about the differential. I'd also be thinking, is this an infarct? And you said that the review of systems was negative.
Yes.
No oral gentle ulcers.
Yeah.
Ahmed, she is asking, there is any, okay.
Yes,
there
yes,
is also, there is from also, we are having a very pioneer friends of us in attendees. They are sending also a note. We have Dr. Ashraf Awaja, and he is saying VKH, and he is asking if there is any history of CAT or subretinal or deep about this one. Also, Dr. Brasan. Yeah, you have any comment, Ahmed, about his what
no,
he's
there's
saying?
No pets. No pets.
Okay. Also, Dr. Brasan Rao, he said autofluorescence plus OCT, though the lesion through the lesions. Yeah, he want maybe to see autofluorescence plus OCT
autofluorescence we did not put it. Yeah, so autofluorescence we did not put it because actually it showed nothing. But I don't have it here, but it did not show anything. So the only
also,
thing showing the...
Yeah, go ahead, Ahmed.
Yeah, and the only thing showing really is the ICG and the fluorescein, and that's the OCT here. It's actually taking part of the lesion. Maybe you're right. Maybe I should have put a better slab, but it's taking part of the lesion here. Just some RPE changes and outer retina and photoreceptor change. But you're right. I mean, I think putting this together, I've missed putting a better part. But I think you can see here the changes in this picture here. Can you see my arrow?
Yeah.
Yes.
Yeah, there's actually the outer retina and the photoreceptors are in a way significantly disrupted in that area here. And I apologize that I didn't put a better section. So that's Ahmed, a great question.
Can you show us also the fundus photographs?
Yes.
Because there are someone comment if there
is
any cupping. Is there any cupping, glaucoma-like cupping?
He had a little bit of cupping, but his pressure was fine. We really did not think much of this.
Okay. Also, I want to ask dear colleagues, they can raise hand. Anyone he can raise hand and participate with us in discussion. Dr. Brasan or Dr. Ashraf, please, or any other. Okay, we can go ahead, Ahmed. So
okay.
now
I think really, you know, it's a privilege really being with the this great panelist, and they really their thoughts were. I mean, I had similar thoughts. We were dealing. I try always to like categorize what we're dealing with. So we were dealing with an area of choroidal outer retinal involvement with the ICG. We were thinking because of the pattern of ICG, that's more of a sort of a choricapillaritis lesion with the way the ICG looks like, more rather than a granulomatous inflammation because of the appearance, the the patchy hypocynescence that we can see on the ICG. So we're thinking there's something going on with the outer retina choroid in this gentleman, particularly the choroid. And then the question really is, does inflammation, as Fahd is saying, or infection or neoplastic? It didn't fit really with anything neoplastic. So we're thinking inflammation, infection, is that an inflammatory choricapillaritis, like for example, something like MP, or this is more of an infectious disease. And when it comes to infectious, bacterial, viral, fungal, protozoal. So I was trying to fit it pretty, could this be bacteria, TB, or syphilis? Could be this viral, doesn't look very much viral, fungal, doesn't look fungal, and also the history and the appearance, and protozoal doesn't look like toxoplasma. So I was thinking really, if this infection, that's more bacterial, and then we're thinking of that differential diagnosis. The outer retina, the hammered RPE and the photoreceptors, as well as the appearance on the OCTA here, makes us think of something, there's an occlusive vasculitis going on in this area. And that's our differential diagnosis here. And you were all spot on, and especially the audience as well. So is this an MP? Is this a localized mutes? Is this actually a serpiginous choroiditis? Not very typical at all. And then birdshot and VKH, again, not typical of birdshot. VKH could be, but then you'll have hot disc and the exudative detachment, which is the hallmark of VKH. And could this be infectious? And I went through bacterial, viral, fungal, protozoal, and then neoplastic, and it doesn't look like. Okay, so workup, mostly important is to exclude infectious, as mentioned by our panel, TB and syphilis, and that's what we did. And
okay,
then
before
we had
you go further, before Ahmed
yes.
going further, we have a few comments just to enrich our discussions. We are having Dr. Brasan Rao. He sent also TBHA / FTA antibodies, ABS.
Yeah.
And also syphilis. From Dr. Ashraf, he said lab for syphilis, TB, sarcoid. This is what he suggests. So to put our panelists and also our attendees in our discussions, so to align the thinking together. I think we are moving in the same way, right?
Yeah, no, and I think we all got the diagnosis really spot on, and the differential diagnosis. So again, I think TB and syphilis here are the most important really. Before, I just want to tell you what I was going to do. So if TB and syphilis comes back negative, and this doesn't look like infection, then I'll put the patient on steroids and see what happens. That's what I would do. So if you're really not sure, you need to get TB and syphilis out of the way. Think of viral, make sure that doesn't look like viral. Think of the other infection as we went through them, and then you put the patient on steroids. Never use intravitreal steroids. You use oral steroids, and then you see what happens. That's how to do it. But this patient came back positive for syphilis, and his RPR was 128. Now it becomes easy. Then you treat them. I treat them usually with penicillin, and then after 48 hours, I give them 40 milligrams of steroid for 2 weeks to avoid the Jerish-Hexheimer reaction. And this patient did fantastic. I mean, he never really confessed to us how did he get this, but we gave him a leeway and said it can be transmitted through dental surgery and maybe blood transfusion, but we left it like this.
But he didn't have any manifestation of syphilis.
No, the rash. So the rash that he had 1 year was most likely syphilis, and I think that's probably the only thing he has. So I think having uveitis with a rash, uveitis arthritis with a rash, uveitis with disc involvement in a male, uveitis with macula involvement in a male, that raises the suspicion of syphilis. But again, yeah, it's I think it's an interesting case really because of the thought process.
And I think also important to remember in this case that we always have to think of syphilis, even if the behavior of the patient doesn't suggest it. So you say he's married, he's monogamous,
Yes,
etc.
exactly.
You still have to think of it, and you still have to test for it. This is a reminder that we have to do that even when the history doesn't suggest it.
Yes.
Is there any, Ahmad, even if you find this, the syphilis is is there any differential diagnosis or diagnosis with that different, even if you find a syphilis that it is sure syphilis, so nothing to do else or to look for any other things or to think about something else?
Yeah, that's a great question. You want to then exclude really other infections that can come with syphilis because of social behavior or sexual behavior as HIV and hepatitis, as we did in this case. Then this is what happened in this case. He was a bit on the big size, so we gave him 60 milligram instead of 40 milligram of steroid, and he did fantastically well, really. And the diagnosis was syphilitic placoid chorioretinitis.
Ahmad, yes.
Ahmad, how long did you keep them on the steroids for? Do you taper
so usually I give them steroid 2 weeks.
6-week period?
Yeah, usually I give them steroid 2 weeks. I don't taper. I just stop.
Okay. Can we connect with Dr. Brasan, if you don't mind, John? Can you connect? John, Brasan, please, can you just open your mic and be with us? Because
just one thing here quickly, as you connect, this is the picture 2 days afterwards, and you can see really the dramatic improvement in his OCTA.
Okay. Brasan, can you be with us? Or?
Yeah, Dr. Excellent case. I just wanted to say that when you look at lesions in the outer retina, and if you're looking at infectious causes, the predominant would be tuberculosis and any treponemial infection, as you rightly pointed out. The second thing is, if you're looking at viral, you're predominantly looking at retina as main site of lesion. I don't know what role does rheumatoid factor have, because generally rheumatoid lesions involve the episclera and sclera, rheumatoid disease. I don't think so it has much of posterior segment involvement unless there's a keratouveitis or something, sclerokeratouveitis.
Yeah, I think it has less vasculitis, really. So I agree. I don't know why we did it. I think you test for rheumatoid and ANA and ANCA mainly in vasculitis, but we tend to get them in most posterior uveitis. I think it just we're ticking boxes, but you're absolutely right. Retinal vasculitis or keratouveitis.
Yeah, and I think it was very classical considering that the patient had rash a year back, and we do see some patients who deny history of multiple partners or even blood transfusion, and despite that you might still get syphilis, though it's very rare in this part of the world, but we occasionally get classic syphilis. And I think, as you pointed out, when you do a multimodal imaging in these patients, you can really pick it as one of your main differentials. Thank you very much for this excellent case.
I think
Dr. Prasan, no, just quickly, not to support Ahmed, but sometimes in the UK or the Western hospitals, the organization will, for example, if you do a vasculitis screen, it will include rheumatoid factor as part of that. So sometimes those tests will be constellated. So we don't have the ability sometimes to just select the ones that we want. And so sometimes, but you're right, I think rheumatoid factor was.
I would like to point out, because in this part of the world, most of our patients are insurance patients. So every test here, we have to really
be justified. Yeah.
So if I ask for rheumatoid in my panel, I would be really pointed out and said that why rheumatoid factor is necessary. And I can't really justify in this way. I'm just for discussion's sake, I'm saying, I'm sure.
Yeah. Yeah, and Lyme antibodies here. Lyme antibodies are not justified as well. I mean, this is we don't have even Lyme in Arkansas. But that case was initially seen by a resident, and they ordered like lots of them. But you're absolutely right.
It looks like a resident's workup, actually.
Yeah,
I'm sure the patient would come to the emergency and the
we didn't neuroimaging. We did not do neuroimaging on him, but you're absolutely right. Yeah. Yeah.
Okay, I think we are having Dr. Ashraf. Dr. Ashraf, if you want to join us, also we can open the mic, please. Can you open the mic for Dr. Ashraf Awaj? He's also having many comments. So, and I think we need just to listen to his comment. Dr. Ashraf, can you join us?
Probably unnecessary in this case.
Yeah, otherwise I will read until he join us if he don't. He's having one comment. He says syphilis can mimic any disease. Can you show OCT pure without color under retina? May we show may I think subretinal dots character for syphilis?
Yeah, I'm sorry, I did not include the slab, better slab, but you can see here really the what I'm showing here, the outer, the photoreceptors and the RPE, the photoreceptors and the external limiting membrane is really hammered off. But yeah, I don't have a better picture in this presentation now on me.
Also,
I really apologize.
He said it mostly white dot syndrome.
Right.
Either BAM or AMN, he is mentioned like this. So that's why I want him to be with us, so to discuss that. What do you think, Ahmad or Rula, or anyone can comment about his?
I think maybe Rula can. I don't want to be talking. Yeah.
Yeah. When I was thinking of pattern recognition, the first thing that came to my mind is AMN. I do agree, but I mean, I would definitely have checked for TB and syphilis, and even if I thought it was AMN and or pattern recognition, I'm thinking of that, and the syphilis came back positive, I consult ID for treating syphilis. But I agree, this pattern is suggestive of such diseases.
Dr. Ala Radwan,
yeah.
I think if you have
I have a comment about that. It's a unilateral case, and I have like ruled my work that unilateral problem should be ruled out infectious causes until proved otherwise, and mainly the lesion in one eye, the other eye is okay, as Dr. Ahmad said. So syphilis TB should be ruled out. Once it's positive, I will not do anything except treating the positive signs I have. The presentation of syphilis and TB, it could be similar to any disease, and also a typical presentation now we are facing in all infectious causes of uveitis nowadays.
I think Dr. Ashraf, you can join us with mic, please. Yes, you can open the mic for Dr. Ashraf if you want to comment before to move to the next presenters. Dr. Ashraf, Mr. John, can you open for Dr. Ashraf Awaja?
I already sent, but no response.
He didn't respond. Okay. There is also one comment from Hazem Khalaf, Dr. Hazem, I think. Any need for CSF analysis in herpetic posterior uveitis? I think maybe something away from the discussions, but if someone wants to comment about these questions.
I think it's, I mean, the case doesn't, Rola said something very nice that
Dr.
Yeah, Dr. Fahd, please go ahead. Please go ahead.
Okay, I think Ahmed, you can go ahead.
Okay, so I think Rola said a very important point, and that's why uveitis really needs to go to uveitis specialist. There's a lot of pattern recognition going on in uveitis. So, and we depend on this. It's a calculated guess. So here, yes, you can think maybe it's viral, but it doesn't look like viral. So I wouldn't go really into like a vitreous tap, for example, in this case. Would you do a CSF analysis? Sometimes they do CSF analysis to look if the HIV if the syphilis is reaching the brain. infection disease here don't do this anymore because they say they already treating as neurosyphilis. But I like what Rola said so much, the pattern recognition.
Yeah.
Yeah, but for viral, we wouldn't do any CSF studies if we're thinking this was viral.
Yeah.
Okay, I think we have only the last comment because we already take a good time for this case. How would you break the news to his partner about syphilis?
That's a good. So that's not my job. That's
there is someone else.
Job.
Someone else will take care about this one.
Yeah, that's the infection disease. And when I spoke to him, he really was like shocked. But you always have to give the patient leeway. So I told him it can be transmitted in certain cases by blood diseases and by blood transfusion and dental infection. Yeah, no, I remember this case so well.
Okay. I think Dr. Ashraf with us. Yes, Dr. Ashraf, if you want to say something before we move to the next. Ashraf? Dr. Ashraf?
I think the mic is not working.
Okay. Okay. I think you can just mute, please. Okay. Thank you very much. So now it's our time to go to Dr. Rola Hammam. Dr. Rola, thank you for accepting our invitation, and we are happy that you are with us. Thanks a lot. Thanks for Ahmed. He is doing the most of the job.
Thank you for the invitation. Thank you, Ahmed and Dr. Mohammed. I need to share my screen, but
okay, Ahmed. Yeah, Ahmed, can you stop sharing your screen, please? Yeah, now you can go ahead.
Okay, so my case is a 44-year-old female. She presented with 3 weeks history of acute headache with bilateral red painful eyes and swelling. The symptoms had not improved with analgesia, and she consulted rheumatology. Her family doctor consulted rheumatology. The investigation by the rheumatologist, they admitted her and they did a panel investigation, including MRI, brain and orbit, chest x-ray, which were negative. They did blood tests, including ANA, double-stranded DNA, ANCAs, complement levels, CRP and ACE, and Borrelia titers were negative. They did CSF studies for cytology, protein, glucose, and culture were negative. Her ASR was 4:1, slightly elevated, and they ended up treating her with steroids, and they tapered it over 3 months. With the taper of steroids, she had recurrence of the symptoms, and they consulted us. On review of systems, she denied any joint GI.
Can you please mute Mr. Ashraf? Yeah, mute Ashraf. John, yeah, please.
Skin or neurologic symptoms, and she had no oral or genital ulcers. She had no cat, no dog. She wasn't a smoker, and she did have a history of eating raw meats. Her vision was 20/20 on the right, 20/40 on the left. Pressures were normal. She had conjunctival superior injection and tenderness, both eyes. She had very fine red precipitates on both eyes with equal sensations of the cornea. Anterior chamber, she had 2+ cells in both eyes and no transformation defects, and the lens was clear. And her fundus looked like this. So she had this elevation at the disc, and she had also the sheathing of the vessels and some hemorrhages in the retina, and it was bilateral. She had late disc hyperfluorescence and some staining where the sheathing is at the vessels close to the nerve. Do you have any question?
So is there any questions to Dr. Rola, Dr. Ahmed, Dr. Ala, Dr. Fahad, Also from Dr. Brasan, he is with us. You are with us here, Brasan? Okay.
So how was it? Did she have any abnormality on her chest X-ray? Any abnormality on
was
serum
negative.
ACE?
Her ACE was normal.
And,
those were done by rheumatology before she came to us. But I completely agree with you. You're thinking that this is sarcoid.
Yeah. Possibly.
Okay. Any comment, Dr. Ala?
Sorry. One question, Mohammed. And any cat scratch,
yes.
any tick bites, anything like this?
No, she never. She doesn't have any exposure to cats and no tick bites. We don't think of Lyme here in Lebanon, and she had no history of travel and no tick bites.
Dr. Ala, if you have any questions. So Fahad, when you're asking these questions, just to clarify for our attendees, why you are asking these questions to exclude what?
So just like Ahmed said, and Rola as well, whenever you deal with anything that's inflammatory, start again. You've got bilateral disc edema. Is it raised intracranial pressure? Is it inflammatory? Is it is it malignant due to raised blood pressure? Is it, and if it's inflammatory, is it infective? Is it autoimmune? Is it masquerade? And in the end, sometimes there's pattern recognition and sometimes things are pathognomic, or you have something like this where you just have bilateral disc edema. And therefore, what would make me think inflammatory, if there was any vitritis, any vasculitis, any retinitis, then I might be thinking inflammatory. However, if the eye is quiet, there's no anterior chamber inflammation, the vitreous is clear, then this could be just straight.
But there is some, Dr. Arula, she mentioned we have plus two cells in the anterior chamber. Okay?
Plus two cells, yes.
Yeah.
Anterior chamber. So therefore, you've got somebody with bilateral disc swelling, with inflammation of the eye. Sarcoid would be my number one, but obviously her chest X-ray and ACE is normal. Having said that, I would probably still get the if I'm still suspecting sarcoid, I would still go get a high res CT. What about multiple sclerosis? Did she have an MRI?
Already, I think
it was negative. So talking about pattern recognition, when I saw this patient also, when I saw this waxy sheathing of the vessels, I too was thinking, is this sarcoid that was missed despite a negative chest X-ray? So I did supplement. They hadn't done EPPD, which I did, and then they hadn't done the syphilis workup, which I also supplemented, and I did order the spiral CT of the chest thin cuts. The PPD and the TPHA came back negative, but her CT chest was positive for
nodules, okay.
Lymphadenopathy, mediastinum, and hilar, large lymph nodes.
Okay.
Pattern that was highly suggestive of sarcoid.
Okay, there is a question also from Dr. Ashraf, also oral ulcer, if there is a history of oral ulcer.
She denied oral genital ulcers. No oral genital ulcers.
No oral genital ulcers, okay. Brasan, if you have any question, I think it's clear. Already you reached to mostly to the diagnosis.
What was the MRI like?
What's that?
What was the MRI of the brain? Considering she had bilateral optic disc swelling with.
They did not do MRI of the brain. She was admitted for the workup by the rheumatology 3 months earlier, and they had done MRI of the brain and orbit, which was negative. MRI wasn't done, and I did not order it.
Surprising, isn't it? Considering that she had headache and she's got bilateral disc edema with sarcoid.
That's a very good point. That's a very good point. But she got better with steroids, and I knew that. that her symptoms did resolve with steroids, but recurred after she stopped them.
Okay, Dr. Ala, what do you think? You are mute, Dr. Ala. Can you unmute yourself, please? Can you unmute? Mute. Okay. Now, please.
I think MRI is very important in this case. I think it's I'm sure that MRI is very important in these cases for us because it will help us if there is neurosarcoid. Also, as Dr. Ahmed mentioned about the bilateral disc edema, even though the course is short of inflammation, but MRI is really significant of our diagnosis and treatment track in these cases. Right. My question for you, are we usually go for biopsy in these cases?
So when the CT shows like this, we consult usually pulmonary, and many times they go for a biopsy if they're not sure. But if the picture is highly suggestive and the eye picture is suggestive, then we go for treatment for the probable sarcoid. Yeah. So in this case, we did not biopsy. Actually, we went ahead with treatment for a probable sarcoid and treat her with steroids and started methotrexate since she failed the first taper of steroids, and she did very well.
Okay. Dr. Ahmed Salam, if you have any comment, you are with us, Ahmed?
I'm sorry, I'll not now. I apologize.
Okay.
Right.
Okay. Okay, Ahmed, thank
you.
I'll
try to come back.
Okay. Okay. So, can you show us what happened later on, Dr. Rona?
So, treated with started steroids 1 milligram per kilogram and tapered over 6 months. Started at the same time on methotrexate 15 milligrams weekly with folic acid, and we kept the methotrexate for 2 years. After which we tapered, and the patient has been in durable remission since 2011 for a very long time. So she had no recurrence after this course of treatment with normal vision, and this is how her fundus looks like after treatment. So when she presented to us, she had already the investigation with a negative MRI, and they had already done LP also. Her family doctor, when they saw the elevated discs, they took it very seriously, and they admitted her for a workup, and rheumatology was consulted, and including LP was done, and all of that they couldn't come up with a diagnosis. Given that ACE is negative and chest X-ray is negative, you'd think that's enough for sarcoid. And I think the point in this case is that if you suspect it. If you suspect a certain diagnosis, and sometimes it's helpful to chase after it. And in this case, the CT chest showed what the X-ray didn't, and that's in a good percentage of patients. And that's why if I suspect sarcoid, I do CT chest, and I do not do a chest X-ray. And I wonder if what's the opinion of the other panelists on this?
Okay, Dr. Ala. If you have any.
Yeah, I'm agree with you. CT is spiral CT is excellent for diagnosis in these cases. AC inhibitors serum level also is very good. But I have a question about the treatment I saw about the methotrexate. Is it preferred to you in these cases to give it orally or parenteral, like intramuscular or subcutaneous? Because really I found this difficult. It's variable result with our patients here in Egypt if you use it orally or parenterally. Parenteral one, intramuscular, is effective or subcutaneous than the oral one. Also about the doses, I saw that you give her about 15 milligram every week. And usually I found this dose is a little bit less than the dose the doses I usually use here in Egypt, about 20, 25 or something, according to the age and the weight of the patients. So is this a regular doses in Lebanon, or is this specific for this case?
Yes. So so you're right. Sometimes we need to go up to 25 milligrams on the methotrexate dose weekly. But this was the BMI of the patient wasn't high, and I started with 15 milligrams, tapered off the steroids. If I had recurrence, then I would have increased the dose, and this was oral. It wasn't subcutaneous. I usually go for subcutaneous if the side effects are not tolerable or the treatment is not effective. And you're right, because with the oral route, it's hard, and the absorption, it's hard to know how much the patient is getting out of the 15 milligrams versus when you give it subcutaneous or intramuscular. So it's definitely more effective when you give it subcutaneous or intramuscular. But some patients prefer the oral route. They're concerned about the needle, scared. They don't want to do it themselves, etc. So many times I do start with the oral, and if they tolerate it, like in this case, and if I don't have to escalate the dose, I don't. So 15 milligrams worked in this case. Other cases, they do need the 25 milligrams subcutaneous. But in this case, this was enough.
Thank you very much. I have just to mention, Dr. Ala, any comments? Sorry,
No, that's good, Dr. Ala. I think the lowest dose of methotrexate is the best dose. The lowest effective dose is good. Thank you.
Dr. Prasan, if you have any comments, you can just mention it. You are now in the board with us, Prasan. Prasan, go ahead.
Yeah, I think I totally agree with Rola and Dr. Ala as well. I think when oral medications are not very effective, subcutaneous or intramuscular is a good option. My only comment was on the CT, if you looked at, there were very large hilar lymph nodes. So I think maybe something would have been picked up by the X-ray chest, if I'm not mistaken.
I totally agree. It's a surprise, but it was done also at the university hospital. So this is the same radiology department who read the chest X-ray and the CT chest, and that was negative. So it was missed, and that's, I think, roughly 30%. You'd miss 30% of lymphadenopathy. But I agree, these are large lymph nodes, but they were missed on an X-ray a few months before. And this is also after steroids. So I agree, this is peculiar, but that's how it was.
There is some comments. Actually, I want to mention it, even though we reached now to diagnosis. We have to tell it before or to mention it. Dr. Radwan Sawas, a VR surgeon, also he's asking if there is any hearing reduction to rule out VKH.
No, shouldn't have any symptoms. So no tinnitus, no hearing reduction, but she had the headaches originally, as I said, which resolved.
Is there any iris nodule?
No.
No. Okay, I think most of the other points already there is comments, but from Dr. Ashraf and Dr. Hussam about methotrexate, how long should be used, lifelong or taper or observe about the methotrexate?
So what I typically do is I keep the treatment. So when we start treatment with immunomodulatory therapy and the patient is off steroids with no recurrences, then I start the clock and I count 2 years. So 2 years on immunomodulatory therapy, no steroids if possible, and no inflammation. I do not decrease the dose during those 2 years. I don't change anything. After 2 years pass, then we can stop. I typically taper, decrease it over a few months, just to check if the immune system is still aberrant or not, meaning any new uveitis attacks. If nothing, then stop it. So 2 years, I don't change the dose, and then either stop or taper off.
Okay, any different protocol, Dr. Ala or Dr. Fahad? Or you are
using
the same?
I agree with Dr. Ola 100% that we should use immunomodulatory for 2 years. Some cases, if there is regression, I start the 2 years from the last time of inflammation. but at least it should be 2 years in immunomodulatory therapy, and then we can stop and check the patient regularly.
I think it's a nice, excellent case, Dr. Arula. Thanks a lot. Now we will move to Dr. Ala. Please, Dr. Ala.
Okay. Yes, John.
Yes, can you share Dr. Ala, please, presentation? Okay. Can you share? John, share please, Dr. Ala. Yes, start from the beginning. Yes. Okay.
Dr. Ala, please go
Okay,
ahead.
next slide, please. Thanks, Dr. Ahmed Salam, for your invitation. Thanks, Dr. Amri, for your generous acceptance to be with our colleague. And I'm happy to join with you the uveitis experience in Egypt. So we'll start with the case 1 of granulomatous uveitis in children. Next, please. This case is about 30 years old boy referred to my clinic with about 6 months of recurrent history of inflammation in his right eye. He was on topical and systemic intermittent courses of steroids medication by non-uveitis doctor, temporarily relieving the redness and photophobia in his left eye. Parents also noticed there is a white lesion inside his right eye. Next, please. Okay, when I examined the patient, is the vision in the right eye is 2400, the other eye 20/20 normal. The IOP is 10 and 14. The anterior segment on the examination was a granulomatous mass in the lower half of the AC in his right eye, about 5 millimeter in 7 millimeter size. The cells in the AC was +3 or 4 with minimal cataract change in his eye with correctopia. The pupil was drawing down to the granuloma. In the posterior segments, there is cells +1 only in the right eye. All other are normal retina and optic nerve in both eyes. Next, please. This is a granuloma, the granuloma inside his eye. You can see ciliary injection and the cornea is clear, but the endothelium, there is this granulomatous mass. You will find that it's two parts. There is a whitish part in the tip of the mountain, and the lower part is fibrovascular proliferation. And this is the most common pattern of granuloma in our country about this disease. And also you'll notice there is correctopia, the pupil is going down. And the cataract change, you cannot see it in the picture. I'm sorry, it's not well clear in this. Next. Okay, so according to this pathology, we have this differential diagnosis: TB, sarcoidosis, herpetic, parasitic, sympathetic ophthalmia, VKH, trauma, toxocara, masquerade. Any comment from our colleague about that?
Dr. Arula and Dr. Fahad, also Brasan, you are with us here now.
I think that's a very reasonable differential diagnosis. Those are the things that are going in my mind. I would more infective rather than inflammatory. Yeah, Dr. Passan Raj made a very good suggestion about juvenile xanthogranuloma.
Yeah.
However, are there some odd river blindness type diseases in Egypt that might give you a granulomatous that we maybe not be familiar here in Europe?
Yeah. So the next slide, please. The next. Unilateral, as we said in the case with Dr. Ahmed, we should rule out the infectious cause. The most common infectious cause in Egypt is TB, and it's endemic in some area. So we should rule out the TB. And the second one, the most common according to our survey in the last 5 years, it's parasitic granuloma. Next slide, please. When we did the survey in Egypt, we found the parasitic granuloma. Please, next. The parasitic granuloma is the most common infectious cause in pediatric in Egypt. And we did this survey after we worked in Egypt for about 2 years, and we found this in about 500 cases. So we consider this case as a parasitic granulomatous infection in this eye patients. Next, please. So in Egypt, this country is agriculture country, and there is the river Nile and the delta. The boys in the summer usually get inside the water for the hot summer there, and the infection of this parasite is common. So we asked about the history of this. If the boy of the or the girls get inside the water during the summer in the last 6 months, we'll find this granuloma is common in our uveitis clinic. But we should ask about the history of TB also. If there is any relative or the patient have chest infection or one of his relatives have infection, we should do tuberculosis scan test. Once tuberculosis scan test is negative and ESR is okay, little bit high, not 10 times or more about the TB infection, we consider this case as parasitic granuloma, and we'll start treatment according to our regimen and protocol we did in Egypt. Next, please. So our scale in Egypt, we should measure the size of the granuloma, and also we should check for the inflammation level. It's mild or moderate or severe, and we score this. And also the complication is glaucoma, cataract, or correctopia. If the score more than 5, in this case, we should go for treatment of steroid, then go for the OR theater, and we should remove this granuloma because it will take long time of treatment with steroid, and our patient will hazard from the complication of systemic and topical steroid. So we should go for surgery if the score of this case is more than 5. And this is what we did in this case. Also, it's about 7 score. So we go for surgery. Next, please. In this case, we did removal of the granuloma. I'm usually doing this through 2 incision at 3 o'clock and 11 o'clock with scissor and forceps of retina forceps. After treating the patient with systemic steroid full dose orally for 1 week before the surgery, and then start to remove this granuloma step by step. The most common complication usually from the fibrovascular proliferation part is hemorrhage during the surgery. If it's happened, we stop the surgery, inject methyl, raise the IOP inside the eye for 2-3 minutes, then we'll aspirate and continue our surgery. Usually after we remove the granuloma and the membrane, we inject subtenon steroid before ending the surgery. In this case, I also inject bevacizumab inside the AC because there was aggressive fibrovascular proliferation in this case. Also, I did a snip at 12 o'clock for the iris to correct the correctopia and improve the vision for the patient. Next, please.
Dr. Ala, can we have some comment or before we go further?
Yeah, no problem.
Okay, there is a question: is there is any skin rash on this patient? I mean, if we are talking particularly about the patient himself.
Yeah, nothing. The patient, usually all these patients are free, just have a history of this granuloma. And,
let us say we don't know it is granuloma or we didn't diagnose it yet.
We have. It's a granulomatous uveitis only.
Do you have a pathology on the granuloma that you excised?
Yeah, all the cases we collect before and we send it for PCR, and we found the PCR positive for mitochondrial PCR test, DNA, mitochondrial DNA of trematode. And we did this for many cases in Egypt, and we established the diagnosis.
Okay, you mentioned, Dr. Ala, there is some cataract changes in the eye, right?
Yeah.
Okay, do you do any surgery in the at the same time, or you will wait and do next time? I mean,
if this cataract is significant, I'm going to do it in the next session. not in the same session.
And that's it.
There is we noticed that after we remove the granuloma and the inflammation decreased, we found in pediatric the cataract change is going down and the vision improve with time.
Okay. There is also a comment from Dr. Prasan. Would UPM be helpful to define the extent of the lesion and to decide whether it's need an iridocyclotomy?
You mean the UPM?
UPM, yeah.
Yeah. In some cases, we found that this granuloma is affecting the angle or the ciliary body and the angle. And sometimes we record some cases in the optic nerve, in the vitreous, in very minimal recorded cases. But mostly the common site is the ciliary body and the angle of the eye, and especially at 6 o'clock.
Okay. If you didn't, for example, think about as xanthogranuloma, and you think maybe it could be a TB. So there have been, he said, Dr. This Prasan mentioned, there have been reports of intravitreal bevacizumab with good result in eyes with vascularized TB granuloma. You have any comment about that?
I have one case, is the same picture, and we found there was a positive history of TB, and we did skin test for TB, and we found it's about 20 millimeter, with ESR is high, milli, and we found the ESR is very high, and his uncle was positive for TB. We treated only with antituberculous orally. Within 3 months, he's cleared and is happy. So in these cases, it should be negative for TB test, and all other is negative, except the history of positive history of going inside the water of the River Nile or the ponds or something like that.
Okay, another question from Dr. Suzanne Ratan. Hello, Dr. Suzanne, I hope you are doing well. What is your degree of dependence on IGRA for TB diagnosis?
I didn't get the question, IGRA.
IGRA.
We depend on tuberculosis skin test only in this case, not with a biopsy or any blood test. Because the most common test here in Egypt is tuberculosis skin test, which give you if the lesion is active, if the TB is active or not. And the second thing, if you ask for 24-hour TB test in the serum, it will be false positive or false negative, because all of us here will have a vaccine, we'll have TB immunization for TB twice in our life. So mostly 24-hour test will be positive in Egypt.
Okay. Yes, we can go further, please. Yes, no.
Okay. So what we did in this case under GA granoma excision, as we said, fibroscopy and berry removal, and we are afraid from hyphemia during surgery. Small pupil sphincterectomy was done at 12 o'clock. Intracameral bevacizumab, in this case, I did it, 2.5 milligram, 0.5, subtenon triamcinolone at the end of the surgery. Next, please. The vision improved markedly in the first week, 20/40. No cells, no photophobia with minimal redness. Patient continue on prednisolone 20 milligram once daily, tapering over 3 months, along with topical steroid tapering also. We stop all medication after 3 months, and the patient, okay, I saw him regularly every year, and he's stable and continue with TB in remission. Okay, you will go for the next case or any question?
Okay, there is only.
Okay.
Is there any other systemic association of the trematode needling system treatment?
Yeah, if we'll go for the next slide, please. I'm prepared this. This is a trematode philophthalmos. This trematode
so you will,
this is the cycle of this trematode. Usually it's inside the eye of the duck, which go inside the water in Egypt and continues the cycle. The problem that is accidentally affect the boys through the mouth or through the eye. We don't know the roots of infection, but it will make no other symptoms in the body except the eye. The good thing that when go for the history of this trematode, we found the Italian doctor who discovered this trematode about 1880 something. He was in Alexandria in Egypt, and he was doing his research, and he discovered for the first time this trematode. So it was discovered in Egyptian ponds and the Delta River of Nile about 200 years ago. So after the high dam came, this infection, I think, increased because, you know, the high dam stopped the change of the water. So like bilharziasis in Egypt, after the high dam, the bilharziasis increased in numbers of infection. Next, please. Also, this is another case, the same thing. We remove it surgically, and the eye will be clear, and everything will be good for the patient. Just remove it surgically if the score is 5 or more. Okay, next, please.
Okay.
So this is second case.
Before we go to the next case,
Okay.
Next case, I just wanted to correct something. I hope you don't mind, Doctor. You said quantiferon would be positive in BCG vaccinated. That's not correct. If you have the TB skin test and you're BCG vaccinated, yes, you will get a false positive. But the interferon assay, which is the quantiferon, should avoid that. So you shouldn't get a false negative, false positive if you are BCG vaccinated and a quantiferon. Does that make sense? So if you do a quantiferon and somebody is BCG vaccinated and is positive, you need to consider whether this patient has latent TB. It shouldn't, the BCG vaccination should not give you a false result. It's only if you do a TB skin test. I just wanted to clarify that for the audience.
Okay, thank you very much.
Thank you for this information, Doctor.
Okay, we can go here fast because we already, Dr. Ala.
Okay, we'll go for the next case. Okay, this is a 23 years old young gentleman came to my Guviad's clinic with severe depression. He lost the vision in his left eye after more than 60 months of management of bilateral uveitis. He had a history of recurrent mouth ulcer with bilateral eye redness and photophobia. He denied any history of genital ulcer, no DVT, no skin lesion, no other systemic affected. Okay, next, please. He had many surgical intervention in his left eye, intravitreal steroid injection, cataract surgery, glaucoma surgery, and finally vitrectomy. He received intermittent courses of systemic and topical steroid, all of them by vitreoretinal doctors. None of them is uveitis doctor. He was diagnosed as Behçet disease, and he had also azathioprine 50 milligram tablets twice daily for more than 6 months, but there is no improvement in his vision. Next, please. So an examination, the right eye is 2200, no PL in the left eye. It's already phytis with hypertony. IOP in the good eye, the OD is 21. Slit lamp examination, clear cornea, AC cells +3. Lens is cataractus, physis pipi in the other eye. Fundus examination, severe vitritis with hazy view in the back of the eye. Next, please. Also, if you see here, no, go back for the mouth ulcer. He was back again to the old slide, please, John.
No, you have to go back, please.
Go back.
Yes.
Yeah. So you can hear, when I saw him in my clinic, still he have active ulcer, but all of the ulcer has the same lips. It's inferior lips, not in the tongue or in the buccal mucosa. Next, please. This is a photo of fluorescein for both eye before he lost the vision in the left eye. I think it was about 1.5 years ago. It was done. You can see here there is bilateral vasculitis with. I'm sorry for the photo. It's not good. but there is haziness of the view with vascularized macular edema, especially at the there is vasculitis in the macular area. This is the left eye, and also there is whitish lesion in the macula in both eye, but it's prominent in the right eye. Next, please. Investigation done by other doctors, all autoimmune markers was done and it was negative. TB scan test was negative. Culture and sensitivity for the last surgery was vitreous biopsy and done only, no PCR was done. 14 years shows no growth in the in his eye because this case is resistant to all medication they have. Next, please. So is it Behçet disease? This is my question. Not respond to the systemic steroid, not respond to immunosuppressant treatment.
We can ask Dr. Rula and Dr. Fahad. Dr. Rula, you are with us?
Yes.
So what do you think? Is it Behçet disease from all this information you have here?
So I can see why they thought it was Behçet disease. I would expect, especially that they've received a significant dose of steroids. You said systemic, intravenous, and oral and local injections. And there was no response or partial response. Did you say no response?
No response. I think Dr. Ali.
Yeah, there is response, but yeah, it's mild response. I think it's about 20-30% response from the reports from the other doctors.
I would not disregard Behçet at the moment based on the outcome. He had so many surgeries when the eye was active.
Yeah, in the
that
left eye.
explain why he ended up with a phthitic eye. Because I mean, you want to avoid surgery if the eye was hot. So I would not disregard Behçet based on the response at the moment. Because if I was thinking this was Behçet, I wouldn't. I mean, I would want to give a biologic anti-TNF as a treatment, as a thioprin is not enough. So I wouldn't. He wasn't immunosuppressed enough. That. If he had received enough steroids, if they pulsed him with steroid, I'm not sure. I mean, how much they gave enough or not. So I would not disregard Behçet at the moment.
What do you put in your mind now, Dr. Rula? What is in your mind? What do you think?
If I'm sure this is not, the TB is negative and I would also check for syphilis. So let's say they're negative. And the patient had a biopsy, also pathology is negative. Is that correct?
Yeah, you have culture and sensitivity only, not PCR test.
And did they do cytology?
No, they didn't do cytology.
Okay. So the culture was negative, they didn't do PCR. If I haven't treated that patient before, I probably want to challenge the case. I might pulse with if that hasn't been done, with a gram of steroids for 3 days and see if there is a response. To see if there is a response, then I'm more inclined to escalate the immunosuppression and start anti-TNF. Now I'm just thinking, was the investigation for infectious enough that was done? So PPD is negative. They've done a culture from the vitreous, which was negative. They haven't done a PCR, granted, but I mean, the culture was negative. I would, if I'm not sure how much steroids they've received, I would pulse them and see how they respond.
Yeah, 100% agree
with you. I'm not thinking this is viral.
Okay.
I'm not thinking it is viral. That's one thing that I would have me stay away from such. It doesn't look like a viral.
Okay, Dr. Fahad, can we ask Dr. Fahad if you have any other comment than what Dr. Rula mentioned?
No, I really like Dr. Rola's approach, because I still think it looks to me Behçet, I have to say. That's the first thing that comes to my mind, particularly the macular infarct. the mouth ulcer. Dr. Ala, did he have a genital ulcer or not?
No, he denied this 100%. There is no history of genital ulcer.
Obviously, in the back of my mind, I always worry about virals. So sometimes, it's a shame that they didn't do a PCR, but I still think the reason why he hasn't responded